Hysteroscopy. Hysteroscopy is the use of a hysteroscope to visualize the endometrial cavity. Hysteroscopy is used to diagnose and treat intrauterine lymphomas, polyps, adhesions, and Mullerian abnormalities. Hysteroscopy is also used to obtain direct intrauterine biopsies to diagnose endometrial hyperplasia or malignancy. The purpose of this video is to discuss the prevention and management of complications during hysteroscopy. After watching this video, residents and medical students should be able to list the contraindications to hysteroscopy, discuss pertinent preoperative planning, and identify and manage hysteroscopic complications. Hysteroscopy can be performed in the office or in the operating room. Office-based hysteroscopy can be used for diagnostic purposes or for minor operative procedures, such as the treatment of small endometrial polyps. Hysteroscopy should be performed in the operating room for patients with cervical stenosis, significant uterine pathology, medical comorbidities, or previously failed or not tolerated office hysteroscopy. Contraindications to hysteroscopy include pregnancy, active genital tract infections, such as chlamydia, gonorrhea, or herpes simplex virus, and a known diagnosis of cervical or uterine malignancy. Two potential preoperative considerations for hysteroscopy include managing cervical stenosis and optimizing intrauterine visualization. For patients with known cervical stenosis, 200 to 400 micrograms of misoprostol can be given buccally, sublingually, or intravaginally the night before surgery. Cervical ripening, although not recommended for routine use, has also been shown to decrease pain during and after office-based hysteroscopy. To optimize intrauterine visualization, hysteroscopy is ideally performed during the follicular phase of the menstrual cycle after the cessation of menses. Thickened endometrium during the luteal or secretory phase may mimic intrauterine polyps. For patients with irregular menstrual cycles, hysteroscopy can be scheduled at any time as their endometrial phase is less predictable. It is not recommended to undergo hysteroscopy during menses as active bleeding may decrease visibility. Pre-treatment with progestins or combined OCPs can be used to thin the endometrial lining to better improve hysteroscopic visualization. Complications that can occur with hysteroscopy include vasovagal reaction, fluid overload and hyponatremia, hemorrhage, uterine perforation, and air embolization. Next, we will discuss the prevention and management for each of these potential hysteroscopic complications.
Manipulation of the cervix and instrumentation of the cervical canal or uterine cavity can trigger the parasympathetic nervous system during hysteroscopy and cause a vasovagal reaction. Common sequelae includes hypotension and bradycardia. Patients undergoing office-based hysteroscopy will be awake and may experience sweating, dizziness, nausea and vomiting, or loss of consciousness. Management of a vasovagal reaction includes assessing vitals and the ABCs of airway, breathing, and circulation. The majority of vasovagal reactions resolve with raising the patient's legs or placing the patient in Trendelenburg position. If bradycardia is present and does not resolve, 0.5 milligrams of IV atropine can be given every 3 to 5 minutes for a total dose of 3 milligrams. Fluid overload and hyponatremia can occur during hysteroscopy. Risk factors include excessive absorption of distending fluid, resection of large or deep lesions, the opening of myometrial sinuses, and high intrauterine pressure. To prevent fluid overload and hyponatremia, it is important to strictly monitor IV fluid hydration and the hysteroscopic fluid deficit. Automated fluid management systems facilitate early recognition of excessive deficits in real time. The maximal deficit for electrolyte-poor fluids, such as glycine, sorbitol, or mannitol, is 1,000 milliliters. The maximal deficit for electrolyte-containing fluids, such as normal saline or lactated ringers, is 2,500 milliliters. Lower thresholds should be considered in elderly patients, patients with multiple comorbidities, and patients with cardiovascular or renal compromise. Consider stopping further fluid infusion for fluid deficits of 750 milliliters for electrolyte-poor fluids and 2,000 milliliters for electrolyte-containing fluids. It is recommended to include anesthesia in the discussion of stopping further fluids and concluding the procedure. If fluid overload and hyponatremia does occur, terminate the procedure, assess hemodynamic, neurologic, respiratory, and cardiovascular status, measure serum electrolytes and osmolality, and administer an intravenous diuretic, such as furosemide if needed. Hyponatremia should be treated by increasing serum sodium levels by 1 to 2 milliequivalents per liter per hour. However, serum sodium levels should not be increased by more than 12 milliequivalents per liter in the first 24 hours to prevent serious neurologic complications, including osmotic demyelination. Patients with severe hyponatremia will require consultation with medical specialists and likely need transfer to the medical intensive care unit.
Clinically significant bleeding or hemorrhage can occur during hysteroscopy. Risk factors include cervical laceration, uterine perforation, adhesiolysis, and resection of cavitary lesions. Management options include applying electrosurgical coagulation to visible lesions, injecting intracervical dilute vasopressin, administering tranexamic acid, using a Foley catheter balloon for cervical tamponade, and manual uterine compression. Laparoscopy with suturing can be used to stop bleeding secondary to uterine perforation. Uterine artery embolization and hysterectomy are used as last resorts for uncontrolled bleeding. The most common perioperative complication during hysteroscopy is uterine perforation. Uterine perforation can occur during cervical dilation, insertion of the hysteroscope, or with use of operative devices such as resectoscopes or morcellators. Techniques used to prevent uterine perforation include performing a thorough pelvic exam prior to hysteroscopy to detect leiomyomas or uterine malpresentation. Both are risk factors for perforation. Ultrasound guidance or flexible hysteroscope can also be used as needed. If uterine perforation does occur, hysteroscopy should be immediately discontinued. Midline perforations infrequently cause morbidity unless laser or electrosurgery are being used. Lateral perforations can damage uterine vessels and cause retroperitoneal hematomas. Laparoscopy should be considered to identify intra-abdominal bowel or bladder injury, manage serosal bleeding, and check for hematomas. Patients undergoing hysteroscopy can experience air embolization. Air embolization is a rare but potentially lethal complication. Common sequelae include hypotension, decreased O2 saturation, and cardiac arrhythmias such as bradycardia or tachycardia. A churning auscultatory sound called a mill-wheel heart murmur is a classical physical exam finding. Patients undergoing office-based hysteroscopy will be awake and may experience dyspnea, chest pain, confusion, and loss of consciousness. Air embolization can be prevented by purging or flushing air from the inflow tubing prior to the insertion of the hysteroscope at the beginning of the procedure. This process should be repeated anytime the inflow fluid bag is changed. Intrauterine pressure should also be monitored and limited. Additionally, providers should avoid repetitive insertion of the hysteroscope through the cervix. This can introduce air into the uterus. If air embolization does occur, immediately terminate the hysteroscopic procedure and call a rapid response. Immediately deflate the uterine cavity and perform Durant's maneuver, which includes positioning the patient in Trendelenburg and left lateral decubitus position. This prevents migration of air to the right ventricular outflow tract or to the lungs. If CPR is required, place the patient supine and in Trendelenburg position.
For more information, please go to APGO Committee Opinion 800 or the OBG Project Hysteroscopy Guidelines. Thank you all for watching.